Today we are presenting a VAP on secondary amenorrhea. After viewing this VAP, you would be able to know the definition and pathophysiology of secondary amenorrhea and can better understand the causes and the clinical features of this condition, and also to understand the investigation and simple management of secondary amenorrhea. We all know that the menstrual cycle is controlled by the hypothalamus, anterior pituitary, and ovary axis, and for menses to occur, the uterus and endometrial lining must also respond to the estrogen and progesterone stimulation. And after the secretory phase, if a pregnancy did not occur, after the luteal phase, menses will ensue after progesterone withdrawal. Thus, if there is any disturbance of the hypothalamus-pituitary or ovarian axis, then menses will not happen, and this will be the primary cause of secondary amenorrhea. So we divide the causes of amenorrhea depending on the area of disturbances. For instance, in hypogonadotrophic hypogonadism, this is a condition where GnRH production is slow, and this could be due to various factors such as stress, weight gain, or weight loss, or anorexia. Sometimes in athletes who exercise a lot, this could also be a very common condition. In a congenital condition, known as common syndrome, there is reduced production of GnRH, and the patient will also present usually with olfactory loss. The second area of disturbance or disorder could be at the level of the anterior pituitary, and very commonly the anterior pituitary could have a tumor which produces prolactin and the high prolactin level, which would then cause a cessation of menses. There are also drugs which could interact with the body to have hyperprolactemia. Very commonly, drugs like cimetidine, mexalone, or even antipsychotic drugs could lead to hyperprolactemia, causing secondary amenorrhea. In a condition known as Sheehan syndrome, where there is a severe postpartum hemorrhage of a woman during the time of delivery, this could cause necrosis of the anterior pituitary because the pituitary organ is one that is supplied by a watershed of blood vessels. As a result, severe hypotension would lead to necrosis of anterior pituitary and thus leading to Sheehan syndrome. There could also be a chromosomal defect, such as Turner syndrome or Mosaic-Turner syndrome, where the ovaries will have premature menopause, and this could lead to secondary amenorrhea. In this case, the FSH and LH would have shown to rise. There are also two conditions known as the resistant ovarian syndrome or premature ovarian failure, where the ovary will fail to respond to stimulation by FSH and LH, thus leading to secondary amenorrhea. The other very common condition is polycystic ovarian syndrome. And the last condition, which is very common, is Asherman syndrome. This is also known as the fibrosis occurring at the endometrium lining. This is usually due to a post-surgical trauma of endometrial lining leading to adhesions. Very commonly, Asherman syndrome follows either an abortion, evacuation of uterus, or even a dilatation and curettage. So, as you can see, we divide the causes of secondary amenorrhea to 5 main groups, so it is easy for you to remember. The most common and important cause that you have to remember is pregnancy, especially for women in the reproductive age group. The second most common would be the hypothalamic causes, such as stress or weight gain. Next would be the polycystic ovarian syndrome, which is under the ovarian dysfunction. Then it would be prolactinoma or Sheehan syndrome. And finally, in a small group, which could be due to premature ovarian failure or premature menopause in less than 40 years. This condition differs from a resistant ovarian syndrome, where there are no more follicles. In the past, we used to have a laparoscopic biopsy of the ovary to differentiate the difference between a premature ovarian failure and resistant ovary syndrome. If there are follicles that are still seen, then the woman is having resistant ovarian syndrome. However, we find the tests to be not consistent, as even a wedge biopsy of an area of no follicle does not conclude that the entire ovary has no follicles. And the last, you have to consider thyroid disorder, such as hyperthyroidism, which could also cause secondary amenorrhea. So we take the complete history of the weight gain, stress, presence of galactorrhea, which can mean hyperprolactinemia thyroid disorder, hirsutism for cases of polycystic ovarian syndrome, menopausal symptoms for women who have premature ovarian failure, and if possible, history of surgery, especially dilatation and curettage or evacuation, and also sexual practice to exclude pregnancy. And this is the Ferriman-Gallwey scoring of hirsutism from grade 1 in mild cases to grade 4 in severe cases, where hirsutism can occur on the chest, abdomen, as well as the back of a woman. So, to investigate for secondary amenorrhea, you have to remember to do a pregnancy test to exclude pregnancy. Take a blood test of follicle-stimulating hormone FSH. If the FSH is more than 30, then this would signify an ovarian failure, and if FSH is very low, then disorder will be dealt at the level of hypothalamus, and if there is a reversal of LH to FSH ratio, then this could be PCOS. And take blood tests to exclude systemic disorder if the woman has symptoms, prolactin as well as the thyroid function test. Lastly, remember that you can conduct a progesterone challenge test to give 5 milligrams of any progesterone. Usually, we will give norethisterone, and if there is withdrawal bleeding, that would signify that there's a presence of estrogen. The woman will need cyclical progesterone to induce withdrawal bleeding. These are very common cases of polycystic ovarian syndrome. And if there's no withdrawal, then the lady may have low estrogen level, thus a combined oral contraceptive pill which contains both estrogen and progesterone might be helpful in such cases. Thus, this concludes the VAP on secondary amenorrhea, where we have discussed the clinical diagnosis of secondary amenorrhea, the clinical features, causes, investigations, as well as simple management of this condition.